Thank you. Thank you for having me. This must be what David Copperfield feels like when he opens up at night. My name's Stephen, and I'll be presenting this case of resident operative volume in the time of coronavirus. And me and the rest of my co-authors have nothing to disclose. So the COVID pandemic, this needs no introduction. It's a case that we're still living with today. What started as a emergence of a virus in parts of Asia and Europe became a worldwide state of emergency in the beginning of March, which quickly came to our shores. At its peak, New York and New Jersey were hit the hardest, and we received over 4,000 new cases and 400 deaths daily. By March 22nd, our governor of New Jersey just stated that all elective surgeries should be canceled. And our program, just like many other programs around the country, had to restructure our residency program to accommodate the needs and change of patient care. So what was our initial response? Initially, we had started by minimizing our in-house complement to allow for a small number of residents to be available in-house to minimize the amount of infection risks amongst our residents. We also were able to pool different programs together who had a smaller number of patient cohorts so that more residents would be available to be activated in case someone were to become sick. In addition to that, we started teleconference sign-out, which allowed residents to share information necessary for continuation of care while minimizing interaction with each other to minimize the risk of exposure. We also had a surgical COVID ICU, which is staffed by our critical care attendings, as well as residents who are on those services and residents who volunteered to be part of that service to minimize the risk of other residents who may be at risk of infection. In addition to that, we had non-surgical critical care attendings take the mantle of taking call to assist those attendings who were taking on the responsibility of the COVID ICU. And finally, we started virtual education, which allowed education to continue. M&M and didactics has also meant for a means for residents and attendings to stay connected to each other during this hard time of the COVID pandemic initial wave. But the big question that we ask ourselves is, what about the operative experiences of residents during this time? And which leads us to the purpose of our studies, to determine how the COVID pandemic affected the operative volume of our general surgery residency program during the initial wave of the pandemic. More importantly, did this effect have a significant impact on resident case volume? And importantly, did this affect our senior residents' ability to graduate and their overall experiences in their final year of training? So this is a retrospective review of all operating room cases in the main OR of our institution from March to May 2018, 2019, and 2020. We were able to take a look at that and compare that to available cases for general surgery residents, case logs on the ACGME website during that same time period. Finally, we were able to look at resident case logs during that time period and compare it to the resident case logs of the entire academic year of 2018, 2019, and 20. And as an observation point, we also looked at the total number of trauma activations that were seen in March to May of 2018, 19, and 20. So again, what about the operative experiences? We have a graph here that shows the blue line shows the total number of operative case volume in our hospital during the time of March to May of the respective years. The green line represents the total resident case log that was logged from the ACGME website. And you can see that there's a significant difference in the resident case volume that was reported from the time of 2019, 2018, 19, and 2020. You can also see that there's a minimal difference in the number of total trauma activations during the time period. When looking at the total number of operative volumes by specialty, there was a significant decrease in the amount of cases in specialties that were highly elective. There was no difference in the case in specialties that were more urgent or emergently operating at that time, including pediatric surgery, surgical oncology, and acute care surgery. whereas the case specialties were a highly elective case volume, including vascular surgery, transplant surgery, elective general surgery cases, and cardiothoracic surgery had a significant decrease in the amount of cases that they had during the time period of the initial pandemic. When looking at the operative case volume across residency training levels, we see that there is a significant decrease in the amount of case volume and case logs in majority of our residents across residency years, including PGY5s, PGY3s, and PGY2s, whereas we do not see a significant decrease in the amount of cases logged in PGY4 and PGY1 years. But looking at the big picture, how did COVID-19 pandemic affect the total case volume in the academic year? In this graph, we can see that there is not a significant difference in the amount of case logs for the entire academic year of 2018, 2019, and 2020. The only significant difference is a small change in the amount of volume in PGY2 case year, but the remaining of our trainees did not have a significant decrease in their case volume across the year. In conclusion, the COVID-19 initial pandemic had a significant impact on resident caseload and operative volume during the initial wave. However, this initial decrease in case volume did not have a significant decrease in the overall caseload in the academic year for our graduating seniors or the remaining of our residents. However, as we continue to live through the COVID-19 pandemic now and in the future, there are many questions that we still have to ask ourselves. How has the pandemic affected our case volume this year? How has our experiences with critically ill patients changed during this past year? And overall, what is our wellness like? Are we more burnt out? Are we able to take care of patients? And how has that experience overall affected the quality of our education and our operative experiences? Any questions?